There we go. If you haven't yet to attend a Spark session, anyone, we've got artists who are drawing our conversations. So speak very descriptively, floridly, if you will. No, you don't have to do that. But we do have an artist drawing the conversation, so we're excited about that. So let's get started. Thank you for attending. The title of this session is Lumion, New Opportunities for Patient Access in a Hybrid Model of Virtual and In-Person Care Delivery. Sounds like exactly the moment we are living in. So with that, I think I will turn it over to the panel. I think the first question that you might have something somewhere else you want to start, but I think the question on everyone's mind is challenges presented by COVID-19. So who from the panel would like to start us off?
So you can go either way. So just very quickly, thank you. Well, let me just say again, express a note of gratitude to everyone that's joining us today. As everyone understands, these sessions will be interactive to the extent they can be. We're not in person, but we certainly will have the chat open. We'll be looking at that. And while Robbie and I will be presenting our thoughts and some of our research, we absolutely want others to engage. So this is a session for you, not for us. And we're going to learn from you as you learn from us. But I think one of the key questions that we have to ask is, as we consider new models of care, the question becomes, are our patients, are our providers, are other consumers really open to new models of care? And there is a resounding yes in response to that question. We won't spend a ton of time on research, but we'll definitely use that to tee off and to provoke some of the conversation. But what are we seeing with our research? For example, we're finding that patients and providers otherwise are open to new models of care across every clinical scenario. And including some of those that are highly complex scenarios. For example, we find that even women who describe pregnancies, let's take that one, who describe their pregnancies as high risk in need of high touch monitoring and close monitoring, they are open to virtual visits. Again, 53% are open to those now, as opposed to 37% pre-COVID. And 60% of all consumers would consider a virtual visit if they had to wait even a day to see their provider. So we are seeing a lot of movement around the virtual environment and the technology-enabled interactions that we are going to discuss further today. And with that, I'll turn it back to Robbie.
So thank you, Alan. And again, thank you to everyone who's attending. I think from our side, I think the most important point to make here to open up is really that necessity is the mother of invention, as Jeff alluded to in the beginning. And I think there's a big concern here for everyone that essentially healthcare has done very well over the years and continue and has and where there isn't any impetus to change, then people tend not to change. But the economic flow in healthcare really comes from employers. And while the stock market's doing well and while employers are doing well, then the money flows through and things will continue. But right now there's a lot of uncertainty, and it's quite possible that over the next 12, 24 months, employers are not going to be quite as happy as they may have been in the past funding the levels of payment that they have previously. And it's very likely that that is going to result in a compression effect on the care delivery side, where fundamentally care is going to have to be delivered at a lower price point. You compound that effect with the increased challenges coming from Walgreens, Walmart, and the new models of primary care that are coming in from the consumer perspective. And there's a risk that there's going to be a lot of need for fairly fleet of foot creativity in the market over the next 12, 24 months. So I think we're going to see a lot of change. And certainly from what we've seen in our research, again, it echoes a lot of what Alan said. Patients love virtual care. They love the convenience of it, but it doesn't change the fact that this isn't a slam dunk for providers. 67% of our providers, and in fact those providers that we've surveyed across the market, have said that their call handling times have increased. And it's not just the call handling times, but the complexity of these calls has massively increased. And this is effectively worsening an existing care coordination problem, where we had increased specialization, where we had increased kind of numbers of handoffs within access. Now what's happening is patients are phoning up about appointments or billing, and they're interweaving into those conversations clinical questions about the appropriateness of what they should do and how they should do it. And that's creating, fairly obvious constraints. The ability for, again, from our surveyed customers, the ability to get clinical resource into patient access centers so that they can handle some of these questions has been a huge factor limiting some of the health systems we've interviewed. And on top of that, there's the obvious challenges around the increase in uninsured patients, etc. And I think the challenge for all of us as we think about this moving forward, there's a giant question mark around the reimbursement piece. It's well reimbursed right now in terms of the telemedicine piece. But we also know that that is unlikely to remain. And also, even though it's reimbursed at the level it doesn't compensate for the fact that poor handoffs and poor continuation of some of those telemedicine visits will result in reduced revenue through lack of testing, follow-up, etc. So for us, we see the opportunity as being more than just how do you pivot to telemedicine, but how do you introduce sustainable models of virtual care that give that consumer experience and improved access and improved consumer kind of capability, but doing that in a sustainable way that actually is not going to result in damaging economics from a health system point of view.
Right. MGMA has done a number of polls and surveys over the last several months about what are the greatest challenges facing your practice, and patient access is often right there at the top. I'd love to ask attendees, if you will, in the chat, assuming let's think about patient access. I wonder if you could come up with a word or two, a brief phrase to describe what part of patient access is the biggest challenge that COVID-19 has presented. I'd love to know. I see safety. Okay. Thank you. Yeah, type it in, and maybe maybe Alan, Robbie, you could address the kinds of patient access challenges you're seeing. How would you characterize it?
If I can just touch on that safety point, I anticipate next year there is going to be a swath of lawsuits from patients that have been engaged in remote care but have not had a good outcome, because the governance and the risk management around how do you effectively deliver that standard of care that you would physically in a remote environment where you can't touch or examine the patient. I think that's a huge issue. And for me, when you think about the sustainability of this, shall we say, convenience from the consumer point of view, the price that you pay for that is understanding how do you match the patient against the service, not just in terms of you need a new patient encounter, but you need a new patient encounter physically, and the next one can be virtual, et cetera, et cetera. So I think there is a lot of work to be done from a governance point of view to be able to do this safely and to put in quality systems that ensure that we can really think about individualized care delivery, because it's no longer about standardized care processes. It's no longer about trying to be efficient in that way. It has to be about standardized decision making and personalized care, where personalized means thinking about the setting and the mode of engagement, not just the clinical factors. So, Alan, what are your thoughts?
No, I think that's well stated, and I see the safety issue coming up in many of the comments here. And in the providers that we're working with in large systems and small systems, this one is a very large and looming concern, as you've articulated so well. There's also, I noticed in here, the comment about provider buy-in, and the provider buy-in comes at two levels. One is the issue of safety. The other is that, medicine is a very personal endeavor. We are used to, as physicians, which I am, to actually laying hands on the patient in some form or fashion. And with the absence of that additional input, it does become more complex as far as how we are going to respond, what we feel comfortable prescribing, recommendations that we make. And I think you really articulated it very well, Robbie, that, there needs to be this personalized approach. And so if you do, in fact, go with a virtual approach and you find yourself in a setting where, in fact, you realize the patient really must come in, I think over time we're going to evolve systems that will pre-screen but will become much more comfortable in the moment to say, I believe you really must come in. And so we're going to have to be able to respond in that way. There's another part to this. You know, access is not only patients coming to us virtually and us coming to them virtually, but in that moment where we have safety concerns or additional concerns, eventually we're going to have to consider other ways to get direct contact. It may be that we will dispatch a home nurse, a home health nurse. We may dispatch Uber or Lyft or somebody to bring them in. So over time, as complex as some of these things are that we're describing, we'll come to understand that we have to have a multimodality approach if we're going to assure patient safety, if we're going to assure quality, if we're going to assure timely care delivery in a way that is most impactful to the patients that we're called to serve.
If I could just pick up on that, Alan, again, sorry, there's a point you made here, which I think is worth doubling down on, the screening event, etc. I think that there is a huge opportunity for us to think about more interesting models of care. And in the US in particular, we have, you know, we've got these incentive and reimbursement frameworks which ensure that effectively you get paid for doing the stuff you do, but it also means that you end up doing the things you get paid for. And that can constrain a lot of the innovation. So I think there is an opportunity to look abroad where some of these constraints don't exist. And I know some of my colleagues at ACOs have done some amazing work by empowering nurses, for example, and particularly in primary care. You know, there is no particular rule that says all primary care needs to be delivered by primary care doctors. Primary care doctors supported by nurse teams and PAs, for example, can do a huge amount of work, a huge amount of good by proactively engaging, screening patients, and then kind of ensuring that you've got, again, this suitability matching. How am I ensuring that the right patient is getting the right engagement with the right type of specialist? So I think that blending is critical. Certainly in the UK, my mother country, we've seen two really interesting interventions. So now every primary care consultation is preceded by a telephone or a video triage. So every consultation will get pre-screened like that. And actually one of the things they've extended just recently is they're doing that for ED visits as well. So if you're going to go into the ED, you phone first, you get screened, and then you get sent either into the ED or in a slightly different setting. Now, obviously, different reimbursement and regulatory frameworks allow different kinds of ways of working, but that does show you what's possible. And obviously, from a patient point of view, you get a very responsive health system. You get really good engagement. You get dealt with quickly. And if there's something that's concerning you, you know, that's your expectations are very well managed. From our surveys, again, what we saw is scheduling, access, ease of access. These are the things that are really front of mind for patient access roles, because the demand, and it's not just about the booking a simple visit necessarily, or even trying to manage lots of different things together. Now it's a much higher volume with a much denser conversation that's much more mixed in terms of administrative and clinical contact, and that's much harder to operationalize and scale.
Yeah.
I'm glad you switched for a second to the patient perspective. In this chat, I see Andy Ferguson said it's cumbersome with quotes. I'm not exactly sure whose perspective he's taking there. It's from the clinician's perspective or from the patient's perspective? There does seem to be a demand from the patient perspective. I wonder if you could talk about that. Andy has clarified from the patient's perspective. Interesting. Is that what others are seeing, that the patients think it's clinical? I've heard some stories that are the opposite of that.
So let me begin to answer, and then Robbie will have perspectives on this as well. But you know, if we look at virtual care, we're certainly talking up to this point from the clinical perspective on either side, provider or patient. But taking it from the patient perspective, and I'm going to cite some MGMA research, and that is that if patients are demanding virtual care and are, as in the introductory comments, are demanding to be seen next day, we know from MGMA research now, this is not advisory board, that if patients are not seen within the week, there's a 25% no-show or cancellation rate. If they're not seen within 1 to 2 weeks, there is a 46% cancellation or no-show rate. And if they're not seen within 3 weeks, there's a 53% reduction or 53% no-show or cancellation rate. So when you think of virtual care, I think you think of it in terms of care and care delivery. But from a strategic standpoint, we also have to think of it as an anchoring mechanism. If in fact we can use our virtual outreach to the patient, who is the one that we're focused on, and do that within a 24-hour period, whether it's an actual care delivery call or interaction, or a call in which we do pre-screening, some of the things that Robbie's talking about as part of the ingrained and DNA of the system in the UK, that is an anchoring mechanism that we're going to increasingly need to consider. It will be a focus. It will allow us to focus on patient safety without question, but it will also allow us a competitive advantage, because as we're going to talk about later, and Robbie's already alluded to, there are plenty of Walmarts in the world and other retail pharmacies that are going to go and deliver the care in the way the patient wants it. If we're a larger system, a larger group, or even an independent group, we've got to get to the patients quickly and to anchor them to us or to our system if we are in fact going to retain them and deliver the care that we know that we can.
Just picking that up, Alan, I would add the thing that those guys are going to offer is a predictable package of care for a predictable price on a predictable kind of delivery timeline. It will be, you'll walk into your local Walmart, splashed across the wall as you go in will be $60 for your checkup. You go in, you can see someone straight away, probably, and then you're done. And it's almost brainless. The point about this is the consumerization piece is not necessarily about providing a phenomenal quality of service. It's about a predictable service. And I think this is the bit that people often miss. What virtual care can help you provide is a way of managing the patient's journey end to end. I would bet, and again, I'm familiar with the research, but the MGMA piece there, what you're seeing when people don't book within a week or they don't book within 2 weeks, it's not that, my perception of this is, it's not that it's the time that matters, it's the uncertainty between what I thought I was going to do and what I ended up doing. And you kind of get this attrition where I wanted this thing and then it's no longer relevant to me. So for me, the consumer experience will be transformed when a consumer can come along into a healthcare setting, ideally a local healthcare setting, and effectively very much like they would go into Starbucks and buy a coffee or something else. It's about a predictable service at a predictable price. And as a healthcare system today, we make this incredibly complicated. We bill retrospectively. We come in and the prices are never necessarily what we thought they were going to be. There's complexity around insurance and copay, and it's just hard. But it's really important to note that when the new entrants come into the market, they're going to be differentiating not on quality, not on having the best physicians, not on having the best, probably not even having the best technology. It's going to be a very simple, predictable service proposition that the consumer can buy, can understand, and they feel like they've got value for. And that isn't necessarily about an objectively high standard of care. It's a predictable standard of care. And I think that's the point. And where we have variability in process, variability in quality, that creates waste, it creates uncertainty, it creates confusion, and you get into this kind of death spiral. So the most important thing to focus on is, how can I take simple things, how can I deliver them in packages that my customers can understand, and then how do I bridge from that into packages, bundles, whatever it is, till you get to the point where, if someone needs a knee replacement, you can put a price on the wall, they know what it is, and they know from the moment they are diagnosed through the moment they're better, they know exactly what's going to happen, how it's going to happen, what that engagement is going to look like, and they don't have to think about it. That should be the goal.
John O'Connor writes, technology barriers, connection issues, just fear on the part of the patient. We've heard this a lot. Do we need to be fighting an educational battle? Is it that they don't know what to expect? You talk about predictability. Do they not know what to expect yet? What do we do?
Yeah, I think without question, the issue of what to expect is a really big issue. The adoption, once patients do know what to expect, is actually pretty strong across all age groups. But I think oftentimes it's the initial interaction, those who have never actually used virtual care in whatever form, where they just don't know. But if they have that experience and see the value and realize that that value extends beyond just addressing their clinical issue, but it also is compounded across their broader social sphere as far as time, gaining back time, the ability to assure safety. We talk about safety in the interaction, but there's the broader concern for safety in regard to just the broader COVID environment. And so if that initial interaction is strong, is solid, is on point, is over time predictable, as Robbie points out, then we find adoption to be very strong. But yes, there is that initial uncertainty, and we do have to address that.
I think there's just on that point, Alan. There's another thing that I've seen. Prior to the pandemic, people were introducing things like virtual care for follow-up and stuff, and that that makes a lot of sense. But actually, the counterpoint to that is it creates fragmentation in the end-to-end experience. And again, we see this from a lot of our customers. They add in lots and lots of technology and lots of point solutions, and actually they all work in slightly different ways. And the consumer gets kind of batted around from one thing to another to another. And that's the opposite of what's really needed. It makes much more sense to think about it from the very first interaction and build from there, and then build the journey kind of longitudinally as the patient follows. And if you do that, then certainly in our data, we've seen huge amounts of engagement, sort of triple roughly what you'll see in many of the EMR portals. But it's not necessarily, it's not a unique technology to us. It's just a different way of engaging. There are many people that do this, and you basically start with the beginning of the patient journey and try to nurture them through it. And that could be manual, it can be technology driven, but it's, and Alan made this point as well, it's getting the patient at the beginning, managing their expectations, and following them through. That is the key to doing this well, I think.
I wonder if there's a perception among patients that this virtual care, this technological stuff is a temporary placeholder because of the pandemic, and then it'll go away once we're out of it, right? Rather than a net new part of the healthcare experience. I wonder if you're seeing that, and where you think delivery models are changing now, and how this is possibly just a net new part of the patient experience.
Well, it's I'm just scrolling through our research because I have exactly numbers on this. So according to our research, over the next 12 months, it seems like so the general consensus view seems to be that over 60% of visits will be in person next year. So the general view seems to be that people will move back to a predominantly in-person video experience. Mm-hmm. That said, there is a strong demand for these remote consultations. But the challenge, and again, in 51% of those surveyed, the challenge is not necessarily implementing that technology or getting people on a Zoom call. The challenge is weaving that in to the general processes and doing that in a safe way. So there is a huge amount of additional work that needs to be done to think that through. I think from a consumer point of view, it's obvious. Why should I take time out of my day to go and see a doctor when I can do it remotely? I think the safety question has not yet become a popular one that is generally well known amongst the general public. And I think it's our responsibility as an industry to make sure that it remains that way, frankly. But I think there's a lot of work to do between now and the future, where I think the governance around that has been sorted out.
Mm-hmm. And so we have the question about payers.
Yeah.
I mean,
that's the $1 billion question, isn't it?
Maybe trillion, right?
Maybe trillion, but I think if you try to look at it from both sides, some payers are extending it already. That's done, and that's fine. the reality is a face-to-face consultation requires more work and is a more productive consultation than a remote one. So it's not unreasonable that payers would take the view that the reimbursement level should be lower. I think how that plays out in reality, we will see. But I think everyone knows that the current situation is unlikely to remain, particularly considering, as Kimberly Shanley is adding in the comments, there's additional work to do around educating the patients, getting them up. It's not obvious that that we have an equivalent level of care being delivered at the moment.
Mm-hmm. Right. Well, this has been interesting. I'd love. I don't. If anybody wants to type in, I'd love to hear where the opportunities are going forward. If it's in broad, if it's follow-up care, primary care, chronic disease, peds. That would be interesting. Behavioral health, right? I mean, we saw that.
Yeah.
Maybe it's behavioral health. I wish we had more time. We've only got a few minutes left, Alan and Robbie. What should you leave us with?
Alan, do you want to go first?
Sure, I'll definitely take a run at this. So we focus significantly in this conversation around telehealth and the virtual care, but access obviously goes well beyond that. And we haven't talked in any detail about specific additional touch points that we have to build into the system that do address the concern for immediacy of care delivery by the right person at the right place at the right time. And so when you begin to look at the broader system, telehealth is an enabling vehicle, is a critically important part of the broader journey. But we have to think in terms of consumers, not only from the patient perspective, but also the physicians who have to access our system, who are frustrated, and we have leakage because they simply can't get into the system. We have to think in terms of where the system is going tomorrow. I have heard numbers from very well-positioned leaders of very large systems that as much as 50% of our current inpatient, outpatient hospital footprint care delivery will move to alternative sites of care within the next 5 years. And if you think in terms of that, think of the imperative to think of the system broadly, using telehealth as one component of the system, but providing access more broadly in response to what is going to be happening. And we can either be reactive or proactive, because if we don't become proactive, for those of us who are on this call, there are others who will in fact, and are in fact being proactive. So I think we have to prepare for a very different future, telehealth being a part of that, but more broadly cast as well.
I'd echo what Alan says, and I think that we have a long way to go to making telehealth sustainable, kind of at industrial strength. And the core of that for me is trying to work out how we get from where we are today, where it's kind of papered together, into a future where you have this fully orchestrated hybrid care model where the right care is being provided to the right patient at the right time in an appropriate setting. There are clearly areas of excellence here where, whether it's proactive nurse-led engagement with primary care, where people are doing wellness visits, there's a whole bunch of examples being listed here in the chat. I know a number of companies doing CBT, for example, which is text-based rather than video-based, because the mode of interaction precipitates a better level of engagement. So there's a huge opportunity to look at technology in the round and say, this is the right mode of engagement for this type of patient and this type of presentation. But we haven't done that. We just kind of lurched from one thing to another. So there's plenty to do. But the elephant in the room is obviously reimbursement. Until this stuff is paid for, or at least some level of conversation is provided that makes it affordable for practices to make the investment and to do the work that they need to support it, then it's, people will do what they need to survive, and that may not be in the long-term interests of the conversation we're having here. So there's a big opportunity. We just need to make sure that the framework is there to support it.
Great. And, you know, and MGMA will continue to listen to groups like this one to figure out where we should be advocating for those, for the right reimbursement and all that. You know, it's great. This is a great conversation. I really appreciate everybody. The good engagement here. And, you know, go to the exhibit hall, and look at solutions. I mean, there's vendors all over the place now with a new take, a new solution to some of these problems. And keep this conversation going. Robbie, yeah.
If I could just add one thing, I saw a question about where some of the research came from, specifically the one referencing the 60% in-person visits. So we've just wrapped up some proprietary primary research into the market, looking at all of this and undertaking interviews with over 100 patient access leaders to try to understand their perspective and how they're considering all of this stuff. We're just wrapping it up now. It'll be published in due course, and I know Alan has done the same thing from a consumer perspective. So we're sharing some stuff before it's published, but we will be publishing soon.
Great. Can people reach out to you? How can they get their hands on that?
I believe we will. Well, we certainly welcome people reaching out. It'll be on our website, and
Sure.
If anyone has an interest, then let us know in the chat and we'll contact you directly. And I believe I'm just being told we have a virtual booth. So come to our virtual booth.
There you go. Go to the virtual booth. All right. Well, thank you so much. Thank you so much, everybody. Have a great rest of the session, and we'll see you soon.
Thank you, everyone, for your time.
Thanks to everyone.
Be well.